Good morning, everyone. Thank you very much, Carl. I really appreciate having the opportunity to be here today and get a chance to talk with you guys about hepatitis C. So what I would like to talk with you about today, if I can get back, is to talk a bit about CDC's response to HCV here in the U.S. We've been working very hard, focusing on persons who were born from 1945 through 1965. I'll talk about some of the reasons that we're doing that, try to give you some background about where we are and ways that we also work with other agencies and HHS. As part of my agenda, I'm going to be discussing and giving you a brief overview on hepatitis C, some background there, morbidity and mortality, the risk and medical indication recommendations that we have out right now and what some of the limitations are of those, the reasons that we started to consider a different strategy, more of a prevalence-based strategy, what those recommendations ultimately look like, and how we went on then forward to do some implementation around them. In the U.S., about 3.2 million persons are chronically infected with HCV. And this is a tremendous concern here for us. It's really about 1.3% of the population. A particular concern is that 50 to 75% of these persons are unaware of their status. And that's one of the reasons that we're really starting to look at creating some different strategies. It's the leading cause of liver transplants as well as liver cancer in the U.S. And you may be aware that liver cancer is really the fastest growing cancer in the U.S. right now, another particular concern for us. HCV deaths have doubled up to about 15,000 from 1999 through 2007, and we know that unfortunately that figure still tends to increase. On this next slide, you see that I'm going to go ahead and point out that aqua line, kind of the blue-green line there, and that really is the number of deaths that we estimate will occur specifically due to hepatitis C in the absence of any testing or treatment. And that's about 900,000 persons among all those infected, or about 1 out of 3 persons who would die from HCV in the absence of any testing or prevention efforts or treatment. The good thing is that there are a number of prevention efforts that we can put into place that can effectively reduce this curve and really limit morbidity and mortality related to hepatitis C. One of the reasons that we're able to do that is vastly improving HCV treatment and advances over the last, let's say, 20 years. In 1991 through about 1993, medications just came onto the market that were really primarily interferon-based. They had a lot of rather difficult side effects, and treatment could be as long as a whole year. But as you can see, over the course of time, up and through really just in the past couple of years, we've seen cure rates increase dramatically. While interferon originally really could only successfully cure about, say, 10 to 30% of persons, that has increased now to as high as 75% and up to 90% and higher of all persons who are able to actually get onto treatment, who are then subsequently cured. So we are in a very exciting time. There were 2 new medications that really have just been approved by FDA over the last month. And we know that in the pipeline right now there are a number of new medications that are coming down, and these new treatment regimens no longer require interferon, which means that the side effects have gotten an awful lot better, and treatment is much shorter now, sometimes as short as 8 to 12 weeks. So now I'm going to talk a little bit about the recommendations that we put out in 1998. These were primarily around risk factors and medical indications. So if a patient came into a physician's office and presented saying that they'd had a history of injection drug use, if they'd had a blood transfusion prior to 1992, or if they had HIV or they had poor liver function tests, then a physician is supposed to order an HCV test. Unfortunately, there are some real challenges around this. Physicians actually don't know anywhere near as much about hepatitis C as we would like for them to, and they understandably don't always want to ask their patients about previous injection drug use. Not necessarily the best way to establish a doctor-patient relationship. Understandably also, many patients don't necessarily want to answer that question. So what would happen is frequently that information goes unsolicited and then unknown. If we were to just use liver function tests as a primer for screening, we would find that we'd miss at least 50% of all chronic infections. So while it is a good tool to help us identify some HCV infections, it still misses a tremendous number of people, contributing to the number of 50 to 75% of persons who are unaware of their infection. So given all this, we decided that we needed to consider a different strategy, perhaps a prevalence-based strategy. A lot of our surveys and research had found that persons born from 1945 through 1965, we saw this real increase in HCV. And we look back, and in terms of the number of infections per year, those increased dramatically through the 70s and 80s. Through many years in the 1980s, as many as 250,000 persons were infected with HCV for a number of different reasons. Subsequently, what that means is that within this birth cohort, the prevalence of HCV is about 5 times higher than among other persons born in other years. Which means that about 1 out of every 30 persons in this birth cohort is infected with HCV, for about 3.25% of all those persons. I should say too that there are about 80 million persons who are born in this birth cohort, frequently referred to as baby boomers. So 80 million persons obviously is an awful lot of people, and if we look at 1 out of 30, they were talking about 2.1 million persons or so who are infected with HCV who were born in these years. We know that about 3/4 of all chronic infections fall within this group. Also, 3/4 of all HCV-associated mortality is within this group. And if we look just at HCV-infected persons in this birth cohort, they actually self-report having 2 or more drinks per day, which is really a tremendously high number given the notorious low self-reporting of alcohol use on surveys like this. This is also a prevention opportunity for us because alcohol really accelerates fibrosis or disease progression. So being able to reduce alcohol is a really relatively straightforward and easy prevention opportunity for us. So our recommendation came out last year, and as you can see, we recommended that all persons born from 1945 through 1965 be tested 1 time for hepatitis C without any prior risk ascertainment. So physicians didn't need to ask about injection drug use. Also, this test really only had to happen once, because it's most likely that someone who was born during these years, 45 through 65, would have been infected a number of years before, 10, 20, 30, or even 40 years earlier. And unless they're actively injecting drugs, they have a very, very low risk of actually acquiring infection. So just testing them 1 time is really all that's required. We also recommended that all persons who were found to be HCV infected receive an alcohol screening, and then counseling is appropriate as well. There are a number of benefits of therapy, and I mentioned just some of them earlier, but we've also recently found in our evidence review that persons who can achieve a cure for HCV actually reduce the risk of developing liver cancer by 75%, which is a tremendous figure. They can also reduce their risk of all-cause mortality by 50%. Now, these are really tremendous benefits, and so this is, again, for us, a tremendous prevention opportunity. So we put out our recommendations in 2012, and then just earlier this year, the U.S. Preventive Services Task Force confirmed these recommendations with their recommendation also to test that same population, persons born from 1945 through 1965. This gives us an alignment across different HHS agencies specifically about our recommendations, which we'd heard from a number of physicians previously had really been a challenge. If one group recommends one thing, another agency recommends something else, it's hard for physicians to know exactly what it is that they're supposed to be doing. So now that these are in alignment, we find that physicians really are starting to kind of understand them a little more and no longer kind of see that particular inconsistency. So we've done an awful lot to implement this. We're really recommending screening as many as 80 million people in the U.S. There are a number of different strategies that we're really going to have to use to try to do that.